Welcome to Night Shift Pulse. Comment your city and the time below. The night connects us all. If you enjoy what you hear, please subscribe. Let's step into the dark. Story 1. The ER Registrar's Incorrect Time of Arrival. I was alone at the registration desk when I noticed the patient had been logged as arriving at 9:47 p.m. The ambulance bay didn't open until 10. I thought it was a typo at first, maybe someone hit the wrong key during the rush. But when I pulled up the record to fix it, I saw my own handwriting in the notes section. My cursive is distinctive, the way I loop the capital letters, the slant I've had since nursing school. It was mine. I corrected the timestamp to 10:12 p.m., saved the file, and moved on to the next admission. I started working as an ER registrar at County General 3 years ago. The night shift suited me. Fewer administrators hovering, less small talk, just the steady rhythm of paperwork and the occasional trauma alert breaking the silence. My job was straightforward. Log patient arrivals, verify insurance, ensure every person who came through those doors existed in our system before they disappeared into triage or beyond. I was good at it, methodical. I prided myself on maintaining clean records. The ER at night has its own ecosystem, fluorescent lights that hum slightly out of sync, the smell of antiseptic mixing with burned coffee from the break room, monitors beeping in waves from the treatment bays behind the security doors. I sat at the front desk with 3 computer screens, a scanner for insurance cards, and a phone that rang whenever someone in the back needed a file pulled or a prior authorization checked. Most nights I could go 2 or 3 hours without standing up. That Tuesday started like any other. My shift began at 10 p.m. I relieved Donna, the evening registrar, who gave me the usual rundown. 2 psych holds waiting for placement, a probable appendectomy being prepped for transfer upstairs, and a reminder that the system had been glitchy all day. She said records were auto-saving twice or reverting timestamps. It had been notified. She clocked out at 10:07 p.m. and I settled in with my lukewarm tea and opened the queue. The first few hours were routine. A laceration from a kitchen accident, a pediatric fever, an elderly man with chest pain who arrived by private vehicle, his daughter filling out forms with shaking hands while I smiled and told her the doctors were fast here, which was sometimes true. I logged each arrival with the same practiced efficiency. Name, date of birth, chief complaint, time in. My fingers moved across the keyboard without thought. Around midnight, I received a fax from an urgent care requesting records for a transfer patient. I pulled the file and noticed the timestamp again. 9:51 p.m. I frowned. The patient had arrived by ambulance, documented clearly in the notes. The ambulance bay didn't unlock until 10 p.m. sharp. It was policy, tied to the security shift change. Before 10, all emergency arrivals were routed through the main entrance and walked back by a guard. After 10, the bay opened and ambulances could drive directly to the dock. I assumed Donna had made a mistake during the chaos of shift change and corrected it to 10:18 p.m., which matched the triage nurse's first vitals check. I saved the file. The system accepted the change without issue. I sent the fax and returned to monitoring the waiting room through the small window to my left. 20 minutes later, I received a message from the attending physician requesting the same patient's file. I pulled it up. The timestamp read 9:51 p.m. again, not 10:18, 9:51. I stared at the screen. I distinctly remembered changing it. I checked the edit log. No record of my correction. No record of anyone accessing the file except me 30 seconds ago. I changed it again. This time I took a screenshot on my phone before saving just to prove I wasn't imagining things. 10:18 p.m. I saved it. Refreshed the page. 9:51 p.m. I called it. The on-call tech, a guy named Greg who always sounded like I'd woken him up, told me he'd submit a ticket and someone would look at it in the morning. He suggested I note the discrepancy in the patient's chart and move on. I did. I typed a brief note explaining the timestamp issue and attached my screenshot. Then I forced myself to focus on the next arrival. But over the next hour, I kept glancing back at that file. The timestamp didn't change again. It stayed locked at 9:51 p.m. I told myself it was a database error, some cached version refusing to sync properly. It happened. Systems were imperfect. Then I noticed another one, a woman who'd come in for a suspected overdose. Arrival time, 9:34 p.m. I hadn't been at the desk at 9:34 p.m. Donna had. But when I opened the notes, I saw my handwriting again. The same loops, the same slant. A detailed description of the patient's presentation, her affect, the smell of alcohol on her breath. Details I couldn't have known because I wasn't there. I checked the log. The file showed I'd created the record at 9:34 p.m., but I'd clocked in at 9:52 p.m. I was still in my car at 9:34 p.m. listening to the end of a podcast before I walked inside. I stood up and walked to the break room. I needed to move, to think. Donna's coat was gone from the hooks. Her travel mug wasn't in the sink. She definitely left. I checked the time clock in the hallway. Her punch-out 10:07 p.m. Mine 9:52 p.m. I went back to my desk. I pulled up the full queue for the night. 7 arrivals so far. 4 of them had timestamps before 10 p.m. 3 had timestamps before I'd clocked in. Every single one contained notes in my handwriting. I opened the oldest file. A man with a scalp laceration. Arrival time, 9:09 p.m. The notes were extensive. I documented his mechanism of injury, a fall from a ladder. I'd noted he was alone. No family present, slightly confused but cooperative. I'd scanned his insurance card. I could see the image of the card in the file, timestamp 9:09 p.m. Device ID matching my scanner. I had not registered this man. I hadn't been in the building. I checked the security footage. We had limited access as registrars, but I could view the lobby in my own desk. I rewound to 9:09 p.m. The desk was empty. Donna was visible in the frame briefly, walking toward the back with a file folder. No one was at the registration computer, but the screen was lit. I zoomed in as much as the system allowed. I could see the glow of the monitors, the faint reflection of the queue interface. At 9:12 p.m., the chair moved slightly. Not a lot. Just the small shift of someone adjusting their weight. But there was no one in the chair. I watched the footage until 9:52 p.m. when I appeared on camera, walking in with my bag and my tea, smiling at Donna as we exchanged our usual pleasantries. I sat down in the chair, the same chair that had moved on its own 40 minutes earlier. I closed the security window and returned to the queue. 8 arrivals now, the newest entry. A child with a fever. Arrival time, 10:03 p.m. That one I definitely remembered. I'd registered the family myself, spoke to the mother, gave the little boy a sticker. I clicked on the file to verify. The timestamp was correct. The notes were correct, my handwriting. But as I stared at the screen, the timestamp changed. Not dramatically. Just 1 minute backward, 10:02 p.m. I refreshed the page. 10:01 p.m. I didn't touch anything, I just watched. The timestamp rolled backwards slowly 1 minute at a time until it settled at 9:42 p.m. The notes updated in real time, expanding, adding details I hadn't written. The mother's demeanor, the child's verbal responses, observations that were accurate but that I hadn't documented because I'd been busy scanning insurance cards. I checked the edit log. All changes attributed to me. Timestamp to 9:42 p.m. I stood up and walked to the triage window. I knocked. The nurse on duty, a woman named Paula who'd worked here longer than I'd been alive, slid the glass open and raised an eyebrow. "Can I ask you something weird?" I said. "Always do," she replied. "Do you remember the kid with the fever, the one who came in with his mom, maybe 30 minutes ago?" Paula consulted her notes. "Yeah, sweet kid. Temp of 102.4, gave him Tylenol waiting on the doctor." "What time did they arrive?" "I triaged him at 10:08 p.m. Not 9:42. Paula looked at me like I'd asked if the moon was made of cheese. "No. Definitely after 10. I didn't start until 10. "Thanks," I said, and closed the window before she could ask why. I went back to my desk and pulled up every file in the queue. 9 arrivals now. 6 of them had timestamps before 10 p.m. All 6 had notes in my handwriting. All 6 had been logged during times I wasn't present. I opened a blank document and started typing out what was happening just to see it in words outside my head. But as I typed, I noticed the cursor moving on its own in the patient queue on the other monitor. A new file was being created. No arrival logged at the front desk. No ambulance radio call. Just a file populating in real time. Arrival time, 9:17 p.m. Chief complaint, follow-up on recurring discrepancy. Patient name, my full legal name. I stopped typing. The file continued filling in. My date of birth, my home address, my employee ID number. In the notes section, my handwriting appeared line by line, as if someone were writing it live. Patient presence with increasing awareness of temporal inconsistency. Reports clear memory of shifts start at 9:52 p.m. despite documentation indicating 9:09 p.m. Exhibits appropriate concern. Cognitive function appears intact. Affect anxious but controlled. Recommended monitoring. I pushed back from the desk. My heart was beating hard enough that I could feel it in my throat. I looked around the empty lobby. No one. I looked at the security camera. The red light blinked steadily. I sat back down and closed the file. It reappeared in the queue immediately. I closed it again. It reappeared. I opened it and scrolled to the bottom of the notes. A new line appeared. Patient demonstrates avoidance behavior. Unable to reconcile documented timeline. Disposition pending. I highlighted my name in the patient field and tried to delete it. The system wouldn't let me. I tried to close the file entirely. Access denied. My phone buzzed. A text from an unknown number. Check your clock in time. I opened the time clock system, my punch-in for the night. 9:09 p.m. Not 9:52, 9:09. I looked at the security footage again. I watched myself walk in at 9:52 p.m. clear as day. But the timestamp on the footage read 9:09 p.m. I checked my text messages. I'd sent a message to my sister at 9:40 p.m. telling her I was about to start my shift. The message was still there. Time-stamped 9:40 p.m. But the time clock insisted I'd been here since 9:09. I pulled up the full schedule. Donna's shift ended at 10:07 p.m. like always. But now a note appeared beneath her punch-out. Overlap coverage provided by evening registrar until transition complete. There was no overlap. There never had been. I started at 10. Donna left at 10. Clean handoff. I returned to my file in the queue. The notes had updated again. Patient increasingly disoriented to timeline. Exhibits confusion regarding shift parameters. Verbal insistence on alternate start time inconsistent with documentation. Memory appears intact for events after documented arrival, but gaps present for initial 43 minutes. Recommend continued observation. 43 minutes from 9:09 to 9:52. I opened my browser and searched my own name in the employee directory. My profile loaded. Shift 7 p.m. to 7 a.m. Not 10 p.m. to 10 a.m. 7 to 7. I looked at my phone again. Another text from the unknown number. You've been here longer than you remember. I stood up and walked to the bathroom. I needed to see myself, to ground myself in something physical. The mirror showed exactly what I expected: my face, my scrubs, my ID badge hanging crooked like it always did. I flipped the badge over. Employee start date, 9:09 p.m. Not the month and year I was hired. A time, today's date, 9:09 p.m. I went back to the desk. 10 arrivals now, all of them time-stamped before 10 p.m., all of them logged by me. I opened the oldest file, the scalp laceration from 9:09 p.m. At the bottom of the notes, a new section had appeared. Initial patient presenting to ER. Registrar role assumed at time of arrival. No prior record of employment. Integration into evening staff seamless. Subject unaware of transition. I clicked on my own file again. The disposition field had updated. Patient remains unable to reconcile documented existence prior to perceived shift start. Timeline anchoring to false memory of external arrival. Condition stable but unresolved. Discharge not recommended. Continued registration duties advised. I looked at the queue. 11 arrivals, 12. The numbers were climbing, but no one was walking through the door. The lobby was empty, the ambulance bay was silent, but the files kept populating, all of them before 10 p.m., all of them in my handwriting. I tried to call my sister. The call connected, but when she answered, her voice sounded distant, like she was speaking through water. I asked her what time I'd texted her earlier. She said she hadn't heard from me in 3 days. I hung up. I checked the message again, still there, 9:40 p.m. About to start my shift, but the message thread above it stopped 3 days ago. I opened the security footage one more time. I watched the empty desk from 9 p.m. onward. At 9:09 p.m. I appeared, not walking into frame. Just there, suddenly sitting in the chair. I watched myself register the man with the scalp laceration. I watched myself work through patient after patient, efficient and focused. At 9:52 p.m. the footage glitched briefly, then resumed. I was still sitting in the same position. No Donna, no transition, just me. The files kept coming. 15 now, 20, all before 10 p.m., all mine. I looked at the clock on the wall. It read 12:37 a.m. I looked at the timestamp on my computer. 9:56 p.m. I opened my file one last time. The final note had been added. Patient has achieved partial awareness of recursive shift structure. Timeline stabilization incomplete. Integration successful. Subject now functions within intended parameters. Further monitoring unnecessary. Registration will continue. The queue refreshed. 23 patients, all logged before 10 p.m. All waiting for me to process their arrivals, their insurance, their existence in the system. I looked at the empty lobby, at the camera's red light, at the glowing monitors. Some shifts don't end when you think they do. They just reset over and over until you stop noticing the seams. I've been logging arrivals since 9:09 p.m. and every time I think I've caught up, the queue refills with patients I've already seen. The timestamps keep rolling backward and my handwriting keeps appearing in files I don't remember creating. Donna doesn't exist in the directory anymore. No one comes to relieve me. But the patients keep arriving, always before 10, always waiting to be registered. And I keep typing because that's what registrars do. Even when the shift never started, even when it never ends. Story 2. The fast-track physician assistant's unclosed chart. The chart belonged to a patient I didn't remember seeing, but the documentation was definitely mine. The phrasing, the clinical shorthand, even the way I formatted the assessment and plan. It was unmistakably my style. Chief complaint, persistent sense of being observed. I read through the history of present illness, the review of systems, the physical exam findings. Everything was thorough, complete, and ready to close. I clicked the button to finalize the chart. The system thought for a moment, then refreshed. Status: still open. I've worked as a physician assistant in the fast-track section of St. Catherine's Emergency Department for 6 years. Fast-track is where we handle the low-acuity cases, minor lacerations, simple fractures, uncomplicated infections, medication refills that couldn't wait until Monday. It's efficient, high-volume work. I see 20 to 30 patients per shift, document as I go, close charts at the end of each encounter, and move on. My productivity metrics are always strong. I don't leave loose ends. The ER runs on a digital charting system that tracks everything. Every vital sign, every order, every note gets time-stamped and attributed to a specific provider. Charts remain open until a disposition is entered, discharged, admitted, transferred, or left without being seen. Once closed, they lock automatically after 24 hours and move to the archive. You can view them, but you can't edit them without submitting a formal amendment request. It keeps the record clean, legally defensible, and impossible to alter retroactively. I first noticed the unclosed chart 3 weeks into a particularly busy stretch of shifts. I was catching up on documentation during a rare lull around 2 a.m., going through my queue to make sure everything was finalized. Most of the charts were already closed. A few needed final signatures or prescription clarifications. But one was still open, flagged as incomplete because the disposition field was blank. I clicked on it. Patient name: J. Calloway. No date of birth listed, which was odd because the system usually required it before you could even create a file. Chief complaint: persistent sense of being observed. I skimmed the note. The history was detailed. The patient reported feeling watched for the past several weeks, both at work and at home. No visual or auditory hallucinations, no paranoia about specific individuals. Just a constant low-level awareness of being monitored. Physical exam unremarkable. Vitals normal. Mental status alert-oriented, no acute distress. I didn't remember seeing this patient, but the attending physician co-signature field was blank, which meant I'd handled the case independently, as I did with most fast-track visits. I must have gotten pulled away before closing it. Maybe a trauma alert or a critical patient needing rapid assessment. It happens sometimes. I added a disposition, discharged with reassurance and a referral to outpatient psychiatry. I signed the chart, closed it. The next night, the chart was back in my queue. Status: open. Same patient, same chief complaint. But the history of present illness had expanded. It now included details I didn't remember documenting. The patient mentioned that the sensation of being watched intensified during evening hours. That they'd checked their home for cameras and found nothing. That they'd started sleeping with the lights on. The physical exam was identical, but the assessment had changed slightly. Instead of just noting anxiety, it now read, "Patient's concern appears disproportionate but persistent. Etiology unclear." I frowned. I checked the edit log at the bottom of the chart. The last modification was time-stamped to my current shift about 40 minutes earlier. The note said I'd reopened the chart to add additional information. But I'd been suturing a forehead laceration 40 minutes ago. I hadn't touched this chart since the previous night. I assumed it was a system glitch. Maybe the chart hadn't properly closed and had somehow re-entered my queue. I reread the note, confirmed the disposition was still set to discharge, and closed it again. The following shift, it was back. This time the chief complaint had changed. Persistent sense of being observed, increasingly certain it's someone familiar. I opened the full note. The history had grown again. The patient now described recognizing patterns in the observation. The feeling peaked during specific times, always when they were alone, always when they were doing something routine, brushing teeth, filling out paperwork, eating lunch in their car. The patient had started keeping a journal to track the sensation. They noted that it felt less like surveillance and more like documentation. I scrolled to the edit log, 4 entries all under my user ID, all time-stamped to times when I was actively seeing other patients or on break. One entry was logged at 3:27 a.m. 2 nights ago. I hadn't worked that night. I'd been home asleep. I called IT. I explained the situation, a chart that wouldn't stay closed, edit log showing my activity during times I wasn't in the system, expanding documentation I didn't write. The technician pulled up my account remotely and ran a diagnostic. He said there were no signs of unauthorized access, no password sharing, no login anomalies. All edits were coming from my authenticated session from the workstation I typically used in Fast Track Bay 3. Could someone else be using my login? I asked. Not unless they have your password and your fingerprint, he said. The system requires biometric confirmation for clinical documentation. Then how is this happening? I don't know, he admitted, but I'll escalate it to the vendor. In the meantime, if the chart keeps reopening, just document it in the admin notes and move on. Don't waste time trying to close it manually. I thanked him and hung up. I returned to the chart. I read through the entire note again, slowly this time. The writing style was mine. The clinical reasoning, the way I moved from subjective complaints to objective findings to assessment, it was exactly how I structured every chart. If someone was mimicking me, they were doing it perfectly. At the end of the note, a new section had appeared under Plan. Patient educated on possibility that observation may be internal rather than external. Suggested self-monitoring and mindfulness techniques. Follow-up PRN. I didn't write that, but it sounded like something I would write. I added a note in the administrative comments section. Chart continues to reopen despite multiple closure attempts. Edits appear under my user ID during times I am not accessing the system. Request immediate IT review. I saved it. I closed the chart. That night I started paying closer attention to my workspace. I worked in Bay 3, a small exam room with a computer workstation, a gurney, a supply cabinet, and a biohazard bin. The room had no windows and one door that opened to the main hallway. Between patients, I locked the screen. I logged out completely during my breaks. I started taking my ID badge with me every time I left the room, even to grab a cup of coffee. The chart reappeared 2 nights later. The chief complaint had changed again. Persistent sense of being observed. Growing suspicion the observer is documenting everything. I sat down and read the entire note from the beginning. It had grown significantly. The history now spanned multiple pages. The patient described their routines in meticulous detail. Their work schedule, their commute, their meals, their sleep patterns. The physical exam section had expanded to include findings I hadn't documented before. A small scar on the patient's left forearm. A slight tremor in their hands when discussing the observation. A habit of glancing toward the door while speaking. These were things I noticed in patients all the time, small details that informed my clinical judgment but didn't always make it into the formal documentation. But here they were, written out in full. I scrolled to the most recent edition, time-stamped 30 minutes ago. I'd been in the break room 30 minutes ago talking to one of the nurses about a staffing issue, but according to the chart, I'd been in Bay 3, conducting a follow-up assessment on Jay Calloway. The new section read, Patient reports increased specificity in their awareness of observation. States they can now identify the observer's patterns. Notes the observer seems to document in real time, particularly during moments the patient is unaware they're being watched. Patient questions whether the observation is consensual. I checked the appointment schedule. No patient named Jay Calloway was registered in the system. No pending appointments, no prior visits except this one chart. I searched the billing records. Nothing. I checked the bedboard. Bay 3 showed as available all night. No patient had been placed there, but the chart insisted I'd seen this patient multiple times, across multiple shifts. I printed the chart. I needed to see it on paper outside the system. The printout was 47 pages long. I took it to my car during my break and read through it in the parking lot under the overhead lights. The documentation was exhaustive. It detailed every aspect of Jay Calloway's life, their habits, their fears, their routines. It described the layout of their home, the route they took to work, the coffee shop they visited on Thursdays. And then I reached the section labeled Observer Documentation Patterns. It described me, my shift schedule, my tendency to chart between patients rather than at the end of the night, the way I rubbed my left temple when I was tired, my habit of leaving my ID badge clipped to my scrub pocket even when I locked the screen. It noted that I worked in Bay 3 almost exclusively, that I preferred the corner workstation with my back to the wall, that I drank black coffee from a thermos instead of the break room pot. At the bottom of the page, a new entry. Patient and observer roles increasingly difficult to distinguish. Boundaries unclear. Consent ambiguous. Documentation continues regardless. I looked up from the printout. The parking lot was empty except for a few scattered cars. The ER entrance glowed in the distance, fluorescent and sterile. I sat there for a long time trying to decide if I should go back inside. When I returned to Bay 3, the chart was still open on my screen. I hadn't closed it before leaving. A new section had been added during the 23 minutes I was gone. Observer left workspace to review documentation externally. Demonstrates awareness, but unclear if awareness is sufficient for cessation. Patient continues to report sensation of being watched. Observer continues to document. I logged out. I went to the charge nurse and told her I needed to leave early, citing a migraine. She was understanding. I clocked out, went home, and didn't return for 3 days. When I came back, the chart was waiting. It had been updated every night I was gone. The edits were still logged under my user ID. The timestamps corresponded to the exact hours I would have been working if I hadn't called out. The chief complaint had evolved. Observer absence noted, but documentation continues. Patient questions whether observation is tied to observer's physical presence or exists independently. I opened the full note. A new section had appeared under Assessment. Patient expresses concern that documentation has become self-sustaining. Observation no longer requires conscious awareness. Pattern established. Role reversal possible. Lines blurred. I scrolled to the final entry, added less than an hour ago. Patient now understands they are both subject and author. Observation is mutual. Chart will not close because encounter is ongoing. Disposition cannot be determined while both parties remain under assessment. I stared at the screen. I looked at the edit log. Hundreds of entries now, all under my name spanning weeks. I clicked on my profile settings. Under active documentation, the system listed one open chart. Patient name, my full legal name. Chief complaint, persistent sense of being observed. I tried to close it. Access denied. I tried to delete it. Access denied. I tried to log out. The system refreshed. The chart remained on the screen. At the bottom, a new line appeared in real time, as if someone were typing it while I watched. Observer now aware of reciprocal documentation. Both charts remain open. Both patients under continuous assessment. Discharge criteria unmet. Encounter continues. I pushed back from the workstation. The screen stayed lit. The chart stayed open. I don't work in Bay 3 anymore. I requested a transfer to a different section, but the chart follows me. It appears in my queue no matter which terminal I use. The documentation keeps growing. My habits, my routines, my fears, all written in my own clinical shorthand. Sometimes I add to it. Sometimes I find sections I don't remember writing, but they're accurate. I don't know if I'm the patient or the provider anymore, and I can't figure out how to close the chart, because every time I try them, it just asks me to document why I think the encounter is over, and I don't have an answer. Story 3, the emergency radiology tech and the blank scan. The CT scan came back perfectly labeled but completely empty. I stared at the monitor, convinced the images hadn't loaded properly, but the metadata was all there. Patient name, exam type, slice thickness, contrast protocol. The image viewer showed the full series, axial cuts from skull base to vertex, 147 slices in total. Each one was properly oriented with anatomical markers. But where the brain tissue should have been, there was only smooth, featureless gray. No ventricles, no sulci, no white matter differentiation, just void. I've been a radiology technologist in the emergency department at Mercy Hospital for 11 years. I specialize in after-hours imaging, CT scans, X-rays, the occasional portable ultrasound when the main department is closed. I work alone most nights, covering everything from midnight to 8 a.m. It's solitary work, but I prefer it that way. There's a rhythm to it. The ER calls with an order. I retrieve the patient, position them correctly, run the scan, upload the images to PACS, and send them back. The radiologist reads remotely from home and sends the report within the hour. Efficient, predictable, and largely silent except for the hum of the machines. The CT scanner in our department is a 64-slice unit installed about 8 years ago. It's reliable, well-maintained, and produces clean images with minimal artifact. The room itself is small and windowless, dominated by the scanner's wide bore and the control station behind leaded glass. I spend most of my shift in that control room watching the live reconstruction feed as the scanner rotates and the images build slice by slice. I've seen thousands of scans. I can spot a bleed, a fracture, or a mass within seconds of the images loading. I know what normal looks like, and this wasn't it. The patient was a middle-aged man brought in by EMS after a syncopal episode. The ER wanted a head CT to rule out stroke or hemorrhage, standard workup. I brought him back from the waiting area, confirmed his identity with 2 identifiers, and explained the procedure. He was cooperative, alert, and oriented. No confusion, no slurred speech. He lay down on the table without assistance, and I positioned his head in the cradle, using foam pads to minimize motion. I stepped into the control room, initiated the scan, and watched the preliminary images populate on the screen. The scan ran normally. The gantry rotated smoothly. The table advanced in precise increments. No error messages, no mechanical issues. But as the slices began to appear, I noticed something was wrong. The first few cuts should have shown the skull base, the dense bone of the petrous ridges, the soft tissue of the brainstem. Instead, I saw labeled anatomy, anterior, posterior, left, right, but no actual structures. Just a uniform gray field, as if the patient's head were filled with water or air, neither of which made any sense. I stopped the scan halfway through and walked back into the room. The patient was lying still, eyes closed, breathing evenly. I checked the positioning. His head was centered correctly. The alignment lasers matched the anatomical landmarks. There was no technical reason for the images to be blank. "Sir, are you feeling okay?" I asked. He opened his eyes. "Fine. Are we done?" "Not yet. I need to rerun part of the scan. The images didn't come out right." He nodded and closed his eyes again. I returned to the control room and restarted the sequence. This time I watched the reconstruction feed continuously, slice by slice. The images appeared in real time, building from the raw data as the scanner rotated, and again, they were empty. Perfectly labeled, anatomically oriented but devoid of any internal structure. I let the scan finish. 147 slices, all blank. I saved the series and uploaded it to PACS, then retrieved the patient and sent him back to the ER. I didn't mention the images. I wasn't sure what to say. I called the on-call radiologist and explained the situation. He pulled up the images remotely. "Is this a joke?" he asked. "No. That's what came out of the scanner." There was a long pause. "These images are useless. Did you check the machine?" "Everything ran normally. No errors, no warnings." "Then it's a calibration issue. Run a phantom scan and call the service engineer in the morning. In the meantime, send the patient for a repeat at the main hospital." I agreed and hung up. I spent the next 30 minutes running a quality assurance scan using the standardized Phantom, a cylindrical device filled with materials that mimic human tissue density. The images came back perfect. The Phantom showed exactly what it was supposed to show. Uniform density, proper contrast resolution, no artifacts. The scanner was functioning correctly, but the patient's scan had been blank. I archived the series and moved on. The rest of the night was routine. A wrist fracture, a chest X-ray for pneumonia, a lumbar spine series for a fall victim. All normal. I forgot about the blank scan until 3 nights later when I received another order for a head CT. Different patient, different chief complaint. But when the images loaded, they were blank again. This time I recognized the pattern immediately. Labeled slices, correct orientation, no anatomy. I stopped the scan and checked the patient. She was a young woman, early 20s, presenting with a severe headache. She seemed fine, no neurological deficits, fully conversant. I explained that the scan hadn't worked and that I'd need to try again. She agreed. I repositioned her, ran the scan a second time. Same result, blank. I pulled up the previous blank scan from 3 nights earlier. I placed the 2 series side by side on the monitor. They weren't identical, but they had the same eerie quality. The absence of structure, the uniform void where a brain should be. I zoomed in on one of the slices. In the featureless gray, I noticed a faint outline. It was subtle, barely perceptible against the background, but it was there. A ghostly silhouette of something that might have been a cerebral hemisphere. I adjusted the window and level settings, tweaking the contrast to bring out hidden details. The outline became slightly more visible. It wasn't a brain, though. It was something else. The shape was wrong, too smooth, too symmetrical. I adjusted the settings further, pushing the contrast to the extreme. The outline resolved into a recognizable form. It was a face, not the patient's face, someone else's. The features were indistinct, but I could make out the suggestion of eyes, a nose, a mouth. The face seemed to be looking directly at me, even though it was just a cross-sectional slice in a CT scan. I reset the window settings. The face disappeared back into the gray void. I sat there for a long time, staring at the screen, trying to decide if I'd actually seen it or if my tired eyes were playing tricks on me. I printed the image. On paper, the face was clearer. Faint, but unmistakably present. I folded the printout and put it in my bag. Over the next 2 weeks, I performed 6 more head CTs. 4 of them came back blank. The other 2 were normal. The blank ones all contained the same faint outlines when I adjusted the contrast. And the faces were always different. One looked elderly. One looked like a child. One had a surgical scar running across the forehead. I started reviewing the patient information for the blank scans. I pulled their medical record numbers and cross-referenced them with prior imaging. Every single one of them had been scanned by me before. Not recently, months ago, sometimes over a year. But they'd all been my patients at some point. I went back through the archive and pulled up their old scans. The images were normal. Brains, bones, blood vessels, all clearly visible. But when I looked closely at the metadata, I noticed something odd. Each scan had been auto-tagged with my initials in the technologist field, which was standard. But there was a second tag in the notes section, one I didn't recognize. Subject imaged by MH. MH. My initials. But I hadn't added that note. It wasn't part of the standard workflow. I searched the PACS database for all scans tagged with subject imaged by MH. There were 43 results. I opened them at random. Most were normal. But 7 of them, when I adjusted the contrast, showed the same ghostly outlines, and the outlines were all faces. I started comparing the faces to the patients. I pulled up their driver's license photos from the registration system and placed them side by side with the scans. The faces in the images didn't match the patients. They matched me. Different ages, different angles, different expressions, but the underlying structure was the same. My face, embedded in their scans. I went back further in the archive. Scans from 2 years ago, 3 years ago. The notes were there too. Subject imaged by MH. I adjusted the contrast on each one. 70% of them contained my face layered beneath the patient's anatomy, faint but recognizable. I stopped searching and sat in the control room with the lights off, just the glow of the monitors illuminating the space. I tried to think through the logic. It wasn't possible for my face to appear in someone else's scan. CT imaging didn't work that way. The machine captured the density of tissues at the moment of exposure. It didn't import external images. It didn't have access to photographs or personnel files. There was no mechanism for this to happen. Unless I was in the scanner. Unless somehow I was being imaged at the same time as the patients. I reviewed the scanner logs. Each scan recorded the exact time and duration of the exposure. I cross-referenced the timestamps with the security footage from the hallway outside the CT room. The footage showed me entering the room with the patient, positioning them, leaving the room, and operating the scanner from the control station. At no point did I enter the scanner myself. But the log showed something else. For each of the blank scans, there was a second exposure recorded. Same timestamp, overlapping duration. 2 scans running simultaneously. One for the patient, one for something, or someone else. I checked the current night's log. I'd performed 3 scans so far, 2 normal, 1 blank. The blank scan showed the dual exposure pattern. I hadn't noticed it during the procedure because the system didn't flag it as an error. It simply recorded both. I went into the scanner room and looked at the table. Empty. I walked around the machine checking for malfunctions or hidden triggers. Nothing. The room was exactly as it should be. But when I stepped back into the control room and glanced at the monitor, the live feed showed a figure lying on the table. I spun around. The table was still empty. I looked back at the monitor. The figure remained. Motionless, centered in the bore, head in the cradle. I couldn't see a face from the angle of the camera, but the body positioning was familiar. The way the hands were folded across the chest, the slight angle of the shoulders. I walked back into the room slowly, still empty. I returned to the control room. The figure was still there on the monitor. I initiated a scan. The gantry began to rotate. The table advanced. The figure didn't move. The images started to load, slice by slice, building in real time. This time they weren't blank. They showed anatomy, a skull, a brain, ventricles, sulci, gray matter, white matter, all perfectly normal, all labeled with my initials, patient name, my name. I stopped the scan. The images froze mid-series. I archived them before I could second-guess myself. I pulled them up on the workstation, 41 slices, all showing my brain. I adjusted the contrast. Beneath my anatomy, layered faintly in the background, were the faces of the patients I'd scanned over the past 2 weeks. All of them stacked together, overlapping, their features blending into a composite image that looked like a palimpsest of identities. I printed one of the slices and held it up to the light. My brain, their faces, all captured in the same exposure, as if the scanner had imaged all of us at once, collapsing time and space into a single frame. The next night, the ER ordered another head CT. I brought the patient back, positioned him, and started the scan. As the images loaded, I watched the monitor. Blank at first, then slowly the outlines appeared, my face again layered beneath his anatomy. I adjusted the contrast. This time, the face was clearer. I was lying on the table, eyes open, staring directly at the scanner. The perspective was impossible. I was operating the machine from the control room. But the image insisted I was in both places at once. I walked into the scanner room. The patient was still on the table, scan in progress. I stood beside the bore and looked inside, empty, except for him. I returned to the control room. The monitor showed both of us now. Him on the table, me standing beside him, looking into the bore. I haven't stopped the scans. Every patient I image now shows my face beneath their anatomy. The radiologists haven't noticed yet, or if they have, they haven't mentioned it. The reports come back normal. The ER accepts the results. The system continues. But I know I'm in every image. I know the scanner is capturing something it shouldn't. And I know that eventually the images will stop being layered. Eventually the patient's anatomy will disappear entirely, and all that will remain is me. Slice by slice, scan by scan. I'm still working the night shift, I'm still running the scans, but I've started to wonder whether I'm operating the machine or whether the machine is operating me. Because every time I position a patient on the table, I feel like I'm lying down too. And every time the scanner rotates, I swear I can feel it imaging me from the inside out. The blank scans aren't errors, they're transitions, and I think I'm almost finished becoming whatever it is the scanner has been documenting all along. Story 4, the ER social worker's deferred consultation. The consult request appeared in my queue at 1:43 a.m., flagged as deferred from an earlier shift. Patient name, A. Brennan. Reason for consult, discharge planning, suspected housing instability. The attending physician's note indicated the patient had been cooperative but vague about their living situation, and a social work assessment was recommended before discharge. Standard referral. But when I opened the full file, I saw that I'd already completed the assessment. My signature was at the bottom of the form, dated 3 days prior. I had no memory of meeting A. Brennan. I've worked as a social worker in the emergency department at Riverside General for 8 years. My role is to assess patients who might need support after discharge. Housing resources, mental health referrals, placement in rehabilitation facilities, or coordination with outpatient services. I work primarily with vulnerable populations, unhoused individuals, elderly patients with limited family support, people in psychiatric crisis. The ER is often their first point of contact with the healthcare system, and my job is to make sure they don't fall through the cracks when they leave. The work is emotionally demanding but manageable if you maintain boundaries. I've learned not to take cases home with me. I document thoroughly, make referrals, and move on. The system is imperfect, but I do what I can within its constraints. Consult requests come through the hospital's electronic system. The ER staff submit them whenever they identify a patient who might benefit from social work intervention. The requests populate in my queue, and I triage them based on urgency. Most I handle during business hours, but I'm often on call for emergencies. situations where a patient is in immediate crisis and can't wait until morning. The deferred consults are different. They're requests that were submitted but not completed, usually because the patient left before I could assess them or because the situation resolved on its own. They stay in the queue until someone marks them as closed. I try to keep the list short, but occasionally one slips through, lingering for days or weeks until I notice it. The A. One Brennan consult had been deferred, but the deferral note didn't make sense. It read, "Patient assessed by MSW on April 19th. Discharge planning deferred pending additional conversation. Patient receptive but uncertain. Follow-up needed." I checked the date. April 19th was 3 days ago. I reviewed my calendar. I'd worked that day, a standard 8-hour shift, and I'd completed 4 assessments. None of them were for A. Brennan. I pulled up my notes from that day. Detailed documentation for each patient I'd seen. Names, ages, situations, outcomes. No mention of A. Brennan. But the signature on the deferral note was mine. The handwriting in the comments field was mine. The phrasing, receptive but uncertain, was exactly how I'd describe a patient who was ambivalent about accepting help. I assumed it was an administrative error. Maybe the consult had been submitted under the wrong name, or I'd seen the patient but filed the documentation under a different case number. It happened occasionally, especially during chaotic shifts. I made a note to follow up and mark the consult as pending clarification. The next day, another deferred consult appeared. Same patient, same note. Patient assessed by MSW on April 20th. Discharge planning deferred pending additional conversation. Patient receptive but uncertain. Follow-up needed. April 20th, yesterday. I reviewed my schedule. I'd been in the office doing paperwork, no direct patient contact. I hadn't been in the ER at all, but the note insisted I'd met with A. Brennan. It included details I hadn't written. The patient's approximate age, late 30s to early 40s, their demeanor calm but evasive. Their stated reason for the ER visit, a minor hand injury that had already been treated. I called the ER and asked if anyone remembered a patient named A. Brennan. The charge nurse checked the log. No record of anyone by that name in the past week. I asked if there had been any hand injuries treated on April 20th. She found 2. Both documented and discharged without social work involvement. I went back to the consult. I read through the attached notes more carefully. They described a conversation I didn't remember having. The patient had been reluctant to provide personal details. They'd mentioned living between places but declined to specify. When I'd asked about family, they'd paused for a long time before saying, "I'm not sure how to answer that." I documented concerns about housing instability and made a referral to a transitional shelter program. The patient had accepted the referral but hadn't committed to following through. It sounded exactly like dozens of conversations I'd had over the years. The phrasing, the observations, the clinical judgment, all mine. But I hadn't had this particular conversation. Not with this patient. Not on that date. I opened the patient's chart in the hospital system. No registration record, no insurance information, no vitals, no labs, no imaging. The only documentation was my social work note. It existed in isolation, disconnected from any actual ER visit. I submitted a ticket to IT explaining the discrepancy. They ran a search. The consult had been auto-generated by the system based on a referral from an ER attending. But when they traced the referral back, the attending's note didn't exist. The order had been placed, but there was no documentation of who had placed it or why. Is it possible I submitted the consult myself by mistake? I asked the IT tech. No. Consults require a physician order. You don't have the access level to generate one. Then where did it come from? I don't know. But it's in the system now, so it's technically a valid consult. You'll need to close it or defer it. I deferred it again. I didn't know what else to do. The following week, I found a voicemail on my work phone. It had been left at 11:53 p.m. 2 nights earlier. I'd been home asleep at 11:53 p.m. The message was from me. My voice, my cadence, my tone. But the words weren't mine. "Hi, this is M. Harper calling from social work. I wanted to follow up on our conversation from earlier today. I know you were uncertain about accepting the shelter referral, but I want you to know the option is still available if you change your mind. You mentioned feeling like you're between places, and I think that program could be a good fit. Please call me back if you'd like to talk more. My extension is 4729. I played the message 3 times. It was definitely my voice, but I hadn't made that call. I checked the call log on my desk phone. No outgoing calls after 5 p.m. that day. I checked my cell phone. Nothing. I called the number displayed in the caller ID field. It rang twice, then disconnected. I tried again. Same result. I went to my supervisor and explained the situation. She listened carefully, then pulled up the consult herself. She saw the same notes, the same signature, the same deferral pattern. She agreed it was strange, but suggested it might be a case of mistaken identity. Perhaps another social worker with a similar name had been using my login by accident. "Do we have another M. Harper in the department?" I asked. "No, but maybe someone with similar initials. I'll check with HR." HR found nothing. No one else in the hospital had initials that matched mine. No one else had access to my login credentials. The deferred consults kept appearing. Every few days, a new one. Same patient, same notes. Each one described a conversation that sounded plausible, emotionally consistent, and clinically appropriate. Each one was something I could have said, might have said, in a similar situation. But I hadn't said it, not to this patient. The notes began to include more personal details. The patient had mentioned difficulty sleeping. They described waking up in the middle of the night feeling disoriented, unsure of where they were. They said it felt like they were living 2 lives simultaneously, one they remembered clearly and one they only glimpsed in fragments. I started recognizing myself in the descriptions. The difficulty sleeping, the disorientation, the sense of fragmentation. These were things I'd been experiencing for the past month but hadn't talked about with anyone. Not my supervisor, not my friends, not even my partner. Yet here they were, documented in a patient file under someone else's name. I began listening to the voicemails more carefully. There were 7 now, all left at odd hours, all in my voice. Some were follow-ups on the shelter referral. Others were more abstract, reassurances that the patient wasn't alone, that what they were experiencing was understandable, that it was okay to feel uncertain about where they belonged. In the most recent message, I heard myself say, "I think you already know what's happening. You just haven't been ready to acknowledge it yet. The deferrals aren't about the patient, they're about you. And I think it's time we stopped pretending this is a case you're managing and started accepting that it's a case you're living." I deleted the message. Then I retrieved it from the deleted folder and saved it to my desktop. I needed proof that this was happening, even if I didn't understand it. I started reviewing all of my closed cases from the past year. I searched for patterns, for anything that might explain why this particular consult kept reappearing. I found 15 cases that had been deferred multiple times before closing. Most were routine, patients who had left before I could complete the assessment, or situations that had resolved without intervention. But 3 of them had the same note structure as the A. Brennan consults. Same phrasing, same signature. Same sense of a conversation I didn't quite remember having. I pulled the patient names. None of them were registered in the hospital system. All of them existed only as deferred consults in my queue. I checked the dates. The first one appeared 8 months ago. The second, 5 months ago. The third, 2 months ago. They were getting closer together. I opened the most recent deferral for A. Brennan. A new note had been added overnight. Patient expresses awareness that consult is recursive, states they are both the subject and the assessor. Describes feeling of being observed by a version of themselves that exists slightly ahead in time. Patient remains receptive but uncertain. Discharge planning inappropriate at this time. Continued assessment recommended. I called my supervisor again. I showed her the note. She read it silently, then looked at me. "This sounds like it's describing you," she said. "I know. Do you think you need to take some time off?" "I don't know. Maybe." She closed the file and folded her hands on her desk. "I think the consult is trying to tell you something, and I think you need to decide whether you're ready to hear it." I went home. I didn't sleep. I kept checking my work email, waiting for the next deferral. It came at 4:17 a.m. Patient has accepted that deferral is a form of avoidance, acknowledges fear of confronting the question the consult is asking. States they are not certain whether they are the person seeking help or the person providing it. Disposition unclear. Case remains open. I typed a response in the notes field. "What question?" The system refreshed. A new note appeared. "Where do you go when you're deferred?" I closed my laptop. I sat in the dark. I thought about the shelter referrals, the patients who lived between places, the ones who couldn't commit to following through because they didn't know where they'd be tomorrow or if they'd remember where they were today. I thought about the conversations I'd had that I no longer remembered, the calls I'd made from my own phone at times I wasn't awake. The notes in my handwriting that documented a life I recognized but couldn't quite claim as my own. The consult isn't about A. Brennan. It's about me. And I think I've been deferred for longer than I realized. I don't know when I started living in the margins of my own documentation, or when the person I thought I was became a case file waiting to be closed. But the deferrals keep coming, and every time I try to follow up, I find another version of myself already there, leaving notes I'll read later and recognize but not remember writing. Some assessments can't be completed because the patient isn't ready. And some deferrals are just another way of saying, not yet, but soon. I think I'm almost ready to stop deferring, but I'm still uncertain, and I think that's exactly what the next note will say. Story 5. The supply room technician's replenishment log. The trauma card in Bay 4 had been restocked before I arrived, logged under my employee ID at 6:41 p.m. I didn't start my shift until 7. I stood in front of the cart staring at the neatly organized supplies, airways, IV kits, scalpel blades, chest tubes, all arranged exactly the way I would have done it. The inventory sheet clipped to the side was filled out in my handwriting. Quantity checks, lot numbers, expiration dates, all correct. My signature at the bottom, dated and timed. But I'd been sitting in traffic on the interstate at 6:41 p.m., 20 minutes away from the hospital. I've worked as a supply technician in the emergency department at Fairview Medical Center for 9 years. My job is straightforward. Maintain the crash carts, restock procedural trays, ensure the trauma bays are always ready. Every piece of equipment has a place, every item has a par level, and my job is to make sure nothing runs out. The ER operates at a pace where seconds matter, and if a physician reaches for a laryngoscope blade or a central line kit and it's not there, someone could die. I take that responsibility seriously. I work the evening shift 7 p.m. to 7 a.m. Sunday through Thursday. The day shift handles the routine restocking, and I cover the overnight emergencies, the traumas, the codes, the unexpected surges when a cart gets stripped down to nothing in the span of 10 minutes. I work alone. The supply closet is my domain. I know every shelf, every cart, every cabinet. I can restock a trauma bay in under 8 minutes without missing a single item. The logs are critical. Every time I touch a cart, I document it. I note what was used, what was replaced, and when. The forms are triplicate. One copy stays with the cart, one goes to the charge nurse, and one gets filed with pharmacy for billing. My handwriting is on hundreds of these forms every week. It's a paper trail that proves the ER was ready, that the equipment was checked, that someone was paying attention. I first noticed the discrepancy on a Tuesday night. I'd clocked in at 7 p.m., dropped my bag in the break room, and started my rounds. I always begin with the trauma bays. There are 6 of them arranged in a horseshoe around the central nursing station. Each bay has a crash cart, a difficult airway cart, and a procedural tray. I check them in sequence, starting with Bay 1 and working clockwise. When I reached Bay 4, the cart was already restocked, fully stocked. Not just topped off, completely replenished as if it had been used during a major resuscitation and someone had rebuilt it from scratch. I opened the drawers. Every item was in its designated slot. The packaging was crisp, the seals unbroken. Whoever had done it knew the system. I pulled the inventory sheet, my handwriting, my signature. Time logged, 6:41 p.m. I checked the charge nurse's desk. She had a copy of the same log filed in the evening batch. I asked her if anyone else had restocked the carts before I arrived. "No," she said. "You're the only supply tech on this shift. Maybe someone from day shift stayed late?" I called the day shift supervisor. He confirmed his team had clocked out by 6:30 p.m. No one had stayed behind. I went back to the cart and inspected it more closely. The items weren't just restocked, they reflected usage. The laryngoscope handle had been wiped down recently. I could see the faint residue of disinfectant on the grip. The scalpel tray had been refilled with a new set of blades, but the packaging was oriented differently than I usually place it. Small differences, but enough to suggest someone had done this recently during an actual resuscitation. I checked the ER log for Bay 4. No documented traumas, no codes, no procedures listed for the past 12 hours. The bay had been empty since the morning. I rewrote the log, dating it correctly to 7:14 p.m. and moved on. I assumed it was an error. Someone had misdated a form, or the charge nurse had filed a log from a previous shift in the wrong batch. It wasn't worth dwelling on. 3 nights later, it happened again. This time in Bay 2. Cart fully restocked. My handwriting. Time logged, 6:38 p.m. I checked the security footage. The hospital kept cameras in the hallways, but not inside the bays for patient privacy. The footage showed the hallway outside Bay 2 from 6 p.m. onward. No one entered or exited the bay between 6:30 and 7 p.m. The cart was visible through the open door in a few frames. At 6:29 p.m. it was partially empty, several drawers open, supplies clearly depleted. At 6:47 p.m. it was fully stocked, drawers closed, inventory sheet clipped to the side. In the 18 minutes between those frames, no one had gone inside. I reviewed the footage again, slowing it down, watching for any movement I might have missed. At 6:41 p.m. the cart shifted slightly, as if someone had bumped it while reaching into a drawer. But there was no one in the frame. I printed the stills and kept them in my locker. Over the next 2 weeks, I found 6 more carts restocked before my arrival, all logged under my employee ID, all documented in my handwriting, all completed during times I wasn't in the building. I started arriving early, clocking in at 6:30 p.m. instead of 7 just to see if I could catch whoever was doing this. But the logs always predated my clock-in time by 10 or 15 minutes. It was as if the restocking was anticipating my arrival, staying just ahead of me. I began to notice something else. The items being replenished weren't random, they corresponded to specific procedures. A difficult intubation kit, chest tube supplies, a cut-down tray. When I cross-referenced the restocked carts with the ER's procedure logs, I found no matching entries. The bays showed no record of the procedures that would have required those supplies, but the carts had been stripped and rebuilt as if the procedures had happened. I asked the attending physicians if they remembered any recent traumas or codes that might not have been logged. None of them did. I checked with the nurses. They had no memory of using the supplies. I even reviewed the billing records. No charges for the procedures that would have consumed those materials. The supplies had been used, but according to the hospital's records, nothing had happened. I started keeping my own log, separate from the official forms. Every time I found a pre-restocked cart, I documented the time, the bay, and the specific items replaced. I photographed the inventory sheets. I saved the security footage. I was building a case for something, though I wasn't sure what. One night I arrived at 6:45 p.m. and went straight to Bay 6. The cart was already restocked. I pulled the log. Time, 6:32 p.m., my handwriting. But this time there was an additional note at the bottom written in the same hand. Airway supplies used during code. Patient unresponsive. Resuscitation unsuccessful. Time of death 6:51 p.m. I looked at the clock on the wall. It was 6:49 p.m. 2 minutes until 6:51. I walked into the bay. It was empty. No patient, no staff, no equipment in use. Just the cart, fully stocked, and the lingering smell of something antiseptic and metallic. At 6:51 p.m., the monitors in the bay emitted a brief, high-pitched tone. The same sound they make when a patient flatlines. Then silence. I checked the ER board. No patient assigned to Base 6. No recent activity. I went to the charge nurse and showed her the log. She read the note about the code and frowned. "There hasn't been a code tonight," she said, "and no one died." "Then why does the log say there was?" She didn't have an answer. I returned to the bay and inspected the cart again. The airway supplies had been used. The endotracheal tube package was open, the stylet was missing, and the laryngoscope blade had fresh residue on it, the kind left behind after intubation. I checked the biohazard bin. Empty. I pulled the security footage for Base 6. At 6:32 p.m., the cart was closed, untouched. At 6:33 p.m., the drawers were open. Supplies scattered on top as if someone had been working quickly. At 6:37 p.m., the cart was restocked, everything in place. In the footage, no one was visible, but the supplies moved on their own, packages opening, items being removed and replaced, the inventory sheet filling itself out line by line. At 6:51 p.m., a shadow passed across the bay. It was brief, indistinct, but it had the shape of a person lying on the gurney. Then it was gone. I stopped watching the footage. I filed the log and moved on to the next bay. Over the following weeks, the pre-restocked carts became more frequent. Nearly every shift, I'd find at least one. The notes grew more detailed. They described procedures I hadn't witnessed, patients I'd never seen, outcomes I couldn't verify. But the supplies told the truth. They'd been used. The carts had been deployed in emergencies that, according to the hospital, never occurred. I started to wonder if I was restocking them myself and forgetting. Some kind of fugue state, maybe, or exhaustion-induced automatism. I set up a camera in the supply closet, angled to capture myself during my shift. I reviewed the footage every morning before I left. The footage showed me working normally, restocking carts, checking inventory, filling out logs. But occasionally there were gaps, moments where the timestamp jumped forward 5 or 10 minutes with no corresponding movement. I'd be standing at a shelf reaching for a box of IV kits, and then suddenly I'd be across the room logging an entry with no memory of the transition. In one clip, I watched myself restock a cart I'd found already completed earlier that night. I moved mechanically, pulling supplies, arranging them in the drawers, filling out the form. My expression was blank. I didn't look tired. I looked absent. The timestamp on the footage read 6:34 p.m. I'd clocked in at 7. I confronted myself in the mirror one morning after my shift. I asked out loud, "Am I doing this?" No answer, just my reflection staring back. The logs keep appearing. The carts keep getting restocked. The procedures keep happening in bays that are empty for patients who aren't there. I don't know if I'm the one doing it. I don't know if I'm working shifts I don't remember, living hours that don't belong to me. But I know the supplies are being used, I know the carts are being rebuilt, and I know my handwriting is on every log documenting emergencies that everyone else insists never happened. Maybe the ER doesn't just run on the procedures we record, maybe it runs on the ones we don't. The codes that fail before anyone knows they've started. The patients who slip through before they're logged. The traumas that exist in the space between one shift and the next. And maybe I'm the one making sure those moments are ready. Even if I don't remember them, even if I'm not sure I'm there when they happen. The cart in Bay 4 was restocked again last night. My signature, my handwriting. Time logged, 6:39 p.m. I clocked in at 7. But when I checked the footage this morning, I saw myself standing in the bay at 6:39 filling out the form. I just don't remember being there. And I think that's how it's supposed to work. Story 6. The emergency unit clerk and the overhead page that never played. The confirmation email arrived at 11:53 p.m., thanking me for announcing a code blue in the West Wing, room 217. I stared at my inbox, confused. I hadn't made any announcements in the past hour. The overhead paging system at my desk had been silent all night except for a routine custodial request around 10:30. I checked the hospital's event log. No code blue had been called in room 217. No code blue had been called anywhere, but the email insisted I'd activated the alert, and it included a transcript of the message I'd supposedly delivered. Code blue, West Wing, room 217. Code blue, West Wing, room 217. All available personnel, please respond. I've worked as a unit clerk in the emergency department at Mercy Regional for 14 years. My station is a small desk positioned at the center of the ER, directly adjacent to the main hallway that connects to the rest of the hospital. From my desk, I can see the ambulance entrance, the triage area, and the corridor leading to the patient bays. My job is administrative. I answer phones, coordinate bed assignments, relay messages between departments, and operate the overhead paging system. When a doctor needs to announce a trauma alert or a nurse needs to call for additional staff, I'm the one who makes it happen. My voice is the one that echoes through the hospital's speakers, calm and clear, no matter how chaotic things get behind me. The paging system is straightforward. I have a microphone at my desk, a button to activate it, and a script for each type of alert. Code blue for cardiac arrest, code red for fire, rapid response for patients deteriorating outside the ICU. I'm trained to speak slowly and repeat the message twice, giving people time to process and respond. After each page, the system logs the event automatically, recording the time, the type of alert, and my employee ID. The logs are reviewed weekly as part of quality assurance. I've made thousands of pages over the years. I know the cadence, the phrasing, the exact tone that conveys urgency without panic. It's muscle memory at this point. I don't think about it anymore. I just do it. The confirmation email was the first sign something was wrong. It appeared in my inbox with the subject line, Overhead Page Confirmation, Code Blue, West Wing, Room 217. I opened it, expecting to find a mistake, maybe a test page someone had triggered accidentally. But the email was detailed. It included the timestamp, 11:47 p.m., and a full transcript of the page. It thanked me for my professionalism and reminded me to document the event in the logbook. I checked my logbook. No entry for a code blue at 11:47 p.m. I checked the paging system's internal log. No record of any page at that time. I called the West Wing nurses' station and asked if there had been a code blue in room 217. The nurse who answered sounded puzzled. "No," she said. "That room's been empty all night. It's scheduled for deep cleaning tomorrow." "Did anyone hear an overhead page about it?" "No." "Why? Was there supposed to be one?" "I don't know," I admitted and hung up. I assumed the email was a glitch, maybe a test message from IT or a delayed notification from a previous shift. I deleted it and moved on. The next night I received 3 more emails, all confirmation messages, all thanking me for pages I hadn't made. One was for a rapid response in the ICU, one for a code red in the cafeteria, and one for a trauma alert in the ER itself. I checked the logs for each. No corresponding events, no pages, no emergencies. I called IT. The technician pulled up my account remotely and reviewed the email server's activity. He confirmed the emails had been generated by the hospital's automated paging system, triggered by my employee ID. But he couldn't find any record of the actual pages in the system logs. "It's like the system thinks you made the pages, but there's no evidence you actually did," he said. "Could someone be using my login?" "Not unless they have your password and your physical access card. The paging system requires both." "Then how is this happening?" "I don't know. I'll submit a ticket to the vendor. In the meantime, keep documenting anything unusual." I started saving the emails. Over the next week, I received 27 confirmation messages, all for alerts I hadn't announced, all for events that hadn't happened. The emergencies described in the emails were specific: room numbers, patient codes, exact times. But when I followed up, the rooms were empty, the patients didn't exist, and no one remembered hearing the pages. I began to notice a pattern. The timestamps in the emails were always a few minutes in the future. If I received an email at midnight, it would confirm a page I'd supposedly made at 12:04 a.m. If I received one at 2:15 a.m., it would reference an alert at 2:22 a.m. The system was thanking me for pages I hadn't made yet. I tested it. One night at exactly 1:37 a.m., I received an email confirming a code blue I'd announced at 1:41 a.m. I watched the clock. At 1:41 a.m., I sat at my desk, hands folded, deliberately not touching the paging system. The button remained unpressed. The microphone stayed off. But at 1:42 a.m., the hospital's event log updated. It recorded a code blue page, attributed to me, timestamped 1:41 a.m. I checked the security footage. The camera above my desk showed me sitting motionless at 1:41, no movement, no page. But the audio feed captured something else. Faintly in the background, I could hear my own voice over the hospital's speakers. "Code blue, South Wing, room 309. Code blue, South Wing, room 309. All available personnel, please respond." I hadn't spoken. The microphone was off, but the page had been made. I went to South Wing, room 309. The lights were off. The room was unoccupied. The bed was stripped down to the mattress. I asked the nurse at the station if anyone had coded. "Not tonight," she said. "Did you hear an overhead page about this room?" She hesitated. I thought I heard something, but it was faint. I figured it was from another floor. I returned to my desk and reviewed the footage again. At 1:41 a.m., my lips didn't move. But in the reflection on my computer monitor, I could see my mouth forming the words. Silently, precisely. as if I were reading the script aloud without making a sound. The emails kept coming. Each one confirmed a page I'd make in the near future. Each one described an emergency that would never be verified. I started ignoring them, deleting them as they arrived. But the pages kept happening. My voice, echoing through the hospital, announcing crises that staff insisted they couldn't hear or couldn't confirm. I began receiving messages from other departments. Radiology called to ask why I'd paged them for a stat portable chest X-ray in a room that didn't exist. The lab called about a critical value I'd announced for a patient with no active orders. Security called about a combative patient alert I'd supposedly made, even though no such patient was in the ER. I apologized each time, insisting I hadn't made those pages. But the logs said otherwise. And increasingly people started saying they had heard my voice, faint but unmistakable, calling them to respond to emergencies that weren't there. One night I received an email at 3:22 a.m. confirming a page I'd make at 3:26 a.m. The subject, overhead page confirmation, general announcement. I opened it. The transcript read, "Attention all personnel, this is the unit clerk. If you are hearing this message, please respond to the main ER desk immediately. I need to confirm that I am the one making this announcement. Repeat, if you are hearing this, please respond." I looked at the clock. 3:24 a.m. 2 minutes until the page I hadn't made yet. At 3:26, my hand reached for the microphone. I didn't decide to do it. My hand just moved as if guided by something outside my control. I pressed the button. My mouth opened. The words came out exactly as they were written in the email. "Attention all personnel, this is the unit clerk. If you are hearing this message, please respond to the main ER desk immediately. I need to confirm that I am the one making this announcement. Repeat, if you are hearing this, please respond." I released the button. My hand returned to the desk. I stared at the microphone. No one responded. The ER remained quiet. The hallways stayed empty. I checked the event log. The page was recorded. Time, 3:26 a.m. I checked my inbox. A new email had arrived at 3:27 a.m., thanking me for the page. I stood up and walked through the ER, looking for anyone who might have heard it. The nurses were charting. The physicians were in patient rooms. The security guard at the entrance was scrolling through his phone. I asked each of them if they'd heard the overhead page. None of them had. But when I returned to my desk, there was a voicemail on my phone. It had been left at 3:26 a.m. I played it. My voice, clear and steady, exactly as it had sounded over the speakers. "This is the unit clerk. I heard the page. I'm responding, but I don't think I'm the one making the announcements anymore. I think the pages are coming from somewhere else. And I think they're calling me." I deleted the voicemail. I didn't leave it for myself. I was at the desk when it was recorded. I didn't call my own extension, but the message was there in my voice, responding to the page I'd just made. The emails continued. Each one confirmed future pages with increasing specificity. They began addressing me directly. Confirmation, overhead page made at 04:11 a.m. Message, unit clerk requested to respond to room 114 for personal consultation. Repeat, unit clerk to room 114. At 4:11 a.m., I found myself standing at the microphone again, pressing the button, speaking the words without consciously deciding to. I went to room 114. The room was dark. The patient board listed it as empty. I stepped inside. The monitors were off. The bed was made, but there was a clipboard on the side table, the kind we use for documenting patient belongings. It had my name on it. Underneath, a single line. Logged as present but unresponsive. Status pending confirmation. I left the room. I went back to my desk. The emails kept arriving. The pages kept being made. My voice kept echoing through the hospital, calling for responses that never came. I don't make the pages anymore. I just wait for the emails to tell me what I'm about to say, and then I say it. Because the system knows before I do. The pages are already confirmed before I press the button. The words are already recorded before I speak them. I think the hospital isn't paging me to make announcements. I think it's paging me to respond, to show up in the rooms it names, to confirm that I'm still here, still listening, still capable of hearing my own voice calling me to places I don't remember agreeing to go. The last email arrived this morning. It confirmed a page I'll make tonight at 11:53 p.m. The message, final overhead page, unit clerk to report to origin point for status update. Repeat, unit clerk to report to origin point. This will be the last confirmation. I don't know where the origin point is, but I think it's my desk. And I think when I sit down tonight and press that button, I won't be making an announcement. I'll be responding to one. And I don't think I'll be coming back. Story 7, the observation physician's incomplete disposition. The patient in observation bed 12 had been awaiting disposition for 16 hours when I started my shift. The chart showed stable vitals, unremarkable labs, no acute findings on imaging. The working diagnosis was benign syncope, likely vasovagal. Standard protocol would be a brief observation period followed by discharge with outpatient cardiology follow-up. But the disposition field remained blank. No orders for discharge, no admission to the floor, no transfer. Just an open chart and a patient waiting for someone to make a decision. I assumed the day physician had been too busy to finalize the paperwork. I opened the note to complete it. Then I saw my own name listed as the attending of record. I hadn't admitted this patient. I'd never seen them before. I'm an observation physician at Northgate Hospital, a role I've held for 7 years. Observation is a liminal space in the hospital. Not quite inpatient, not quite outpatient. Patients stay for up to 24 hours while we monitor them, run tests, and determine whether they're safe to go home or need full admission. It's a high turnover unit, efficient and protocol driven. Most cases are straightforward. Chest pain ruled out for cardiac origin, minor head injuries observed for delayed bleeds, dehydration being rehydrated. My job is to make decisions quickly and move patients through the system. Disposition is the culmination of that process. After observation, I document my assessment, choose an outcome, discharge, admit, or transfer, and close the chart. The bed becomes available and the next patient moves in. The system depends on throughput. An incomplete disposition creates a bottleneck, tying up resources and leaving patients in a state of uncertainty. The patient in bed 12 was a man in his mid-40s brought in by EMS after collapsing at a grocery store. Witnesses reported a brief loss of consciousness, maybe 10 seconds, followed by full recovery. No seizure activity, no incontinence, no post-event confusion. By the time he arrived, he was alert and conversational. The initial workup was negative. EKG normal, cardiac enzymes normal, head CT normal. Orthostatic vitals showed no significant drop. The classic presentation of a simple faint. I reviewed the timeline. He'd been admitted to observation at 6:47 a.m. It was now 10:32 p.m. Over 15 hours in the same bed with no updates to the chart. I checked the nursing notes. Vitals recorded every 4 hours, all stable. The patient had eaten, walked to the bathroom unassisted, and spent most of the day reading on his phone. No complaints, no changes, just waiting. I walked to bed 12 and pulled back the curtain. The man was lying in bed, eyes half closed, not asleep but resting. He didn't look up when I entered. "Good evening," I said. "I'm Dr. Keegan. I'm one of the observation physicians. I'm going to be taking over your care." He opened his eyes fully and looked at me. "You already did." "I'm sorry?" You've been my doctor all day. I glanced at the chart on the mobile workstation. My name was listed as the admitting physician. Time 6:47 a.m. I hadn't worked this morning. My shift started at 7 p.m. I think there's been a documentation error, I said. I'm just starting my shift, but I'm going to review your case and get you discharged as soon as possible. You said that this morning, he replied, and again this afternoon. I didn't know how to respond. I checked his wristband. Name, date of birth, medical record number, all matched the chart. I pulled up the physician notes on the computer. There were 3 entries, all signed by me. The first at 6:51 a.m. shortly after admission, the second at 12:14 p.m., the third at 5:48 p.m. Each note documented a conversation with the patient, a review of the labs and imaging, and a plan to discharge pending final observation. But none of the notes included an actual disposition. Each one ended with, "We'll reassess and finalize discharge." I'd been at home at 6:51 a.m., asleep at 12:14 p.m., commuting at 5:48 p.m. Do you remember talking to me earlier today? I asked carefully. You came by 3 times, he said. Each time you said you were going to discharge me soon. Each time you left and didn't come back. What did we talk about? You asked how I was feeling. I said fine. You asked if I remembered passing out. I said no. You asked if I had any chest pain or dizziness. I said no. Then you said you'd finish the paperwork and send me home, but you didn't. I scrolled through the chart. The notes were thorough, but they were repetitive. Each one covered the same ground, asked the same questions, reached the same conclusion. The phrasing was mine, my sentence structure, my clinical shorthand. If someone had forged these notes, they'd done it perfectly. I'm going to step out and review your chart more carefully, I said. I'll be back shortly. That's what you said last time. I returned to the physician workstation and pulled up the observation unit schedule. The day shift physician was listed as Dr. Ellen Marsh. I called her. She answered on the 3rd ring, sounding annoyed. This is Keegan, I said. I'm following up on a patient in observation bed 12. The chart says I admitted him this morning, but I wasn't working. Do you remember seeing this patient? Bed 12? Let me check my list. A pause. No, I didn't see him. According to the board, he's been yours all day. But I wasn't here. Then I don't know what to tell you. Maybe someone used your login by mistake. 3 times? Look, I had 22 patients today. I don't have time to track down documentation errors. If the chart says he's yours, he's yours. Just discharge him and move on. She hung up. I sat at the workstation and read through the notes again. Each one was slightly longer than the last, as if I, or whoever was writing them, was adding more detail with each iteration. The most recent note, signed at 5:48 p.m., included observations I couldn't have made unless I'd been in the room. It described the patient's effect as resigned but cooperative, noted that he'd asked twice about his estimated discharge time, and mentioned that he'd been checking his phone frequently, possibly texting family. I checked the security footage. The observation unit had cameras in the hallways, but not in the patient bays. The footage showed the hallway outside bed 12. At 6:51 a.m., a figure in a white coat entered the bay. The angle didn't show a face, but the build and gait looked like mine. At 12:14 p.m., the same figure. At 5:48 p.m., again. I watched the most recent clip closely. The figure approached the bed, paused briefly, then exited. The timestamp matched exactly 5:48 p.m. I'd been in my car at 5:48 p.m., stuck in traffic, listening to a podcast. I checked the login records. Each note had been entered from a workstation inside the observation unit. My credentials, my password. The system even recorded the exact terminal, workstation 7, the one closest to bed 12. I returned to the patient. He was sitting up now, arms crossed, watching the hallway through the gap in the curtain. "Can I ask you a question?" I said. He nodded. "When I came by earlier today, or when you think I came by, did I say anything unusual? Anything that didn't sound like a normal doctor visit?" He thought for a moment. "You asked me if I knew where I was. And you said the hospital?" "No. You asked if I knew where I was before I came here. You asked if I remembered making a decision to come. What did you say?" "I said I didn't decide. I passed out and the ambulance brought me." "What did I say to that?" "You said that's what I thought too. Then you left." I felt something cold settle in my chest. I pulled up the note from that visit, the 12:14 p.m. entry. At the end, there was a line I hadn't noticed before. "Patient unable to recall volitional decision to present for care. State's arrival was involuntary, consistent with pattern." "Consistent with what pattern?" I muttered aloud. The patient looked at me. "You said that earlier, too." I opened the labs again, looking for anything that might explain this. Toxicology screen negative, metabolic panel normal, thyroid function normal. The syncope workup was textbook unremarkable. There was no medical reason to keep him here. But the disposition field remained stubbornly blank, and every time I tried to type in discharge, my hands hesitated. I looked at the patient. "Do you want to go home?" "Of course." "Then why haven't you asked to leave? You've been here over 15 hours. You could have walked out at any time." He frowned. "I thought I needed your permission." "You don't. You're an adult. You can leave against medical advice." "I tried," he said quietly. "This afternoon. I got dressed, took off the wristband and walked to the door. But when I got to the hallway, I couldn't remember where the exit was. I stood there for 10 minutes looking at the signs, but none of them made sense. So I came back. I pulled up the architectural layout of the observation unit on the computer. It was a simple rectangular floor plan. The exit was clearly marked, a straight path from bed 12 to the main corridor. "Did anyone stop you?" "No, I just couldn't leave. It felt like I didn't know how." I printed a map and handed it to him. "This is the way out. If you want to go, you can go." He took the map but didn't look at it. "Will you discharge me?" "I can't discharge you if you're not my patient, and I don't think you are." "Then whose patient am I?" I didn't have an answer. I left the bay and returned to the workstation. I opened my own employee file. Start date, credentials, shift assignments, all correct. But under active patients, the system listed 43 open charts assigned to me. I'd seen 9 patients tonight. That meant 34 charts were open from previous shifts. I pulled up the list. Most of them were from observation. Patients I didn't remember admitting, all with incomplete dispositions, all waiting for a decision I apparently hadn't made. I opened the oldest one. A woman admitted 11 days ago with chest pain, workup negative, my name as the attending, 3 progress notes, all signed by me, all ending with, "Will reassess and finalize discharge." She was still in the system, listed as occupying bed 8. But when I checked the current bed board, bed 8 was occupied by someone else entirely. A new admission from tonight. I called the nursing station. "Can you tell me who's in observation bed 8 right now?" "Bed 8? The nurse checked. "That's the chest pain from earlier tonight, just came up from the ER." "And before that? Was there anyone else in that bed today?" "No, it's been empty since this morning." "What about 11 days ago?" A pause. "I don't go back that far. Why?" "Never mind." I hung up and opened the chart for the patient in bed 12 again. The length of stay had updated. 18 hours now. I scrolled to the bottom of the note. A new line had appeared. Disposition pending physician acknowledgement of recursive admission. Patient remains in observation indefinitely. Decision delayed due to unresolved status of attending physician. I stared at the screen. I hadn't written that. I checked the edit log. The last entry was from me, time-stamped 3 minutes ago. But I'd been on the phone 3 minutes ago. I looked up at bed 12. The curtain was still closed. I stood and walked toward it, then stopped. I had the sudden, overwhelming sense that if I pulled back that curtain again, I wouldn't see the patient. I'd see myself. I returned to the workstation and tried to close the chart. The system wouldn't let me. Error message. Disposition required before closure. I typed discharge in the disposition field. The system accepted it and then immediately reverted to blank. I typed admit. Same result. I tried transfer. The field cleared itself. A new message appeared at the bottom of the screen. Discharge criteria not met. Attending physician must complete observation period before disposition can be determined. I checked the clock. 18 hours and 31 minutes since admission. My shift was supposed to end at 7 a.m. That was 8.5 hours from now. I opened the note again. The final line had updated. Patient continues to await disposition. Attending physician demonstrates increasing awareness of unresolved status. Both parties remain in observation. Discharge pending mutual acknowledgement of indeterminate conclusion. I stood up and walked to bed 12. I pulled back the curtain. The patient was gone. The bed was made, the monitors off. The IV pole unused. The chart on the mobile workstation was closed. I checked the system. Bed 12 still showed as occupied. Length of stay, 19 hours, 2 minutes. I returned to the workstation. My active patient list still showed 43 open charts. But now, at the top of the list, there was a new entry. Patient name. My name. Admitting diagnosis. Observation of indeterminate disposition. Attending physician unable to finalize discharge due to recursive documentation. Length of stay, 7 years, 3 months, 14 days. The time I've been working in observation, I tried to log out. The system refreshed. The chart remained open. The disposition field remained blank. I don't think I've been discharging patients. I think I've been admitting myself over and over under their names, delaying decisions I was never authorized to make because I couldn't recognize that the person awaiting disposition was me. The observation period isn't over. It's just beginning. And I think the only way to complete it is to stop trying to close the charts and accept that some patients never leave. They just wait and document and hope someone else will make the decision they couldn't. But there's no one else here. Just me and the beds and the charts that won't close. And the clock that keeps counting hours I don't remember working. I think I've been in observation for a very long time. And I don't think I'm ready to be discharged yet. Because I still don't know where I'd go if I left.